Yeah, we got it. Okay. All right. I got this under control. Hi, everyone. Thanks for coming to our didactic. We're going to talk about homelessness in the emergency department, and we're going to talk a little bit about myths and misconceptions, as well as the evidence that either perpetuates or dismantles those, and some practical solutions. So I'm really glad to see everyone here. We have no disclosures, but I am very welcome to any if you want to offer me any later. Start with some introductions. We have a really great team here today with lots of experts. I myself am Caitlin Reyes. I'm an assistant professor of emergency medicine at Yale. I am also a NIDA DARS scholar, and my research is at the intersection of housing and health, and specifically substance use disorder and addiction medicine. I'll pass the mic on to...
My name is Dr. Christine Shaw. I am a global emergency medicine and social emergency medicine population health fellow at the University of Alabama in Birmingham, and my research focus is, of course, people experiencing homelessness.
I'm Hannah Janeway. I am an emergency physician. I work in the community, also at the VA Medical Center in Los Angeles, and I also work about 3/4 time helping to run a program out of the street medicine program at UCLA. So I'm either doing some admin work for that or working on the van.
And my name's Keen Preston Sooney. I'm the acting chief of emergency medicine at the VA Greater Los Angeles and faculty at UCLA. I do work on improving care for emergency care for people experiencing homelessness at the West LA VA.
Okay, so today our objectives are hopefully to convey to you the diversity within the experience of homelessness, as well as sort of an understanding of all the structural factors that beget the conditions that perpetuate homelessness, to challenge some of the biases and stereotypes that are kind of rampant in our specialty, and to unpack some of the research and how that contributes to it and how it could dismantle some of that. We're also going to talk about some practical interventions, and we'll have some small group activities at the end. So this is the real test. Like, you know, this may be overly optimistic. I'm going to say this is my first time using Poll Everywhere, and I'm sure a lot of people in the room probably do it better than I do, but let's see if it works. Pull out your phones and try that QR code for me, and we'll try our first question. Oh, log into Poll Everywhere. Are you guys seeing a question?
Go back to the QR.
I will. It's asking me to log in.
Yes. Yeah, the question's
It is. Okay, great. Start answering the question, and I'll start logging in. Sorry about this. They told me it would be installed. Cool. This is cool.
All of the protection.
Right? Oh, no.
Just to get an idea, how many people in this room actually currently work like in a space or like some sort of project that deals with individuals who are unhoused? Okay, a fair number of you. Yeah. Does anyone work like on like in street medicine or like out in the community with unhoused individuals? Okay, one person.
Cool.
Okay, awesome.
I think we're back in business. Okay. Why is that not up there? Display settings. Redo it. Yeah. Right? Current
Yeah,
slide?
just redo it. Yeah, from current slides.
Oh.
There we go.
Oh, yeah. All right. So there was a question. It let you vote. We're cooking with gas. Awesome. No. All right. Well, man, this really doesn't work when it doesn't work. Yeah, cool.
We'll just go on with that.
We'll just go on, except that it won't let me skip slides. Uh-uh.
You gotta exit it and we'll just...
We're just going to skip that. Okay, so we'll just do this by show of hands. What % of Americans do you think have experienced homelessness in their life? Would you say 12 to 15, 8 to 10%, 4 to 5%, 1 to 2%. And here's a really annoying part. I'm not going to tell if you were right. But like some of these answers are going to be in the presentation. And I'm going to hand it to Hannah. And I think you just have to like go to current slide, not on a poll everywhere one, or it won't work.
Is this a pull everyone one? No.
If you just scroll down to where you start.
Right here.
The definitions.
Okay. Oh, wow. What, close what?
Whatever this process is.
I would just close that.
Yeah. Yeah, the whole thing. It's not even showing the slides over there.
I'm gonna just close it out. Just close everything. All right, we're back in business. All right, so it seems like a fair number of you already work in this space, but I think it's really important to go over definitions because this is something I come up with a lot in the emergency department or when trying to admit a patient. And I think we all can agree that, the traditional image of like an unhoused person is someone who is like unhoused and unsheltered, right? It's like a person sleeping on a sleeping bag somewhere on a sidewalk or in a tent, and people consider that to be like the only definition of someone who is quote unquote homeless. But in reality, housing insecurity is a much larger sort of umbrella, and it really just means any lack of security in housing. And this is important because a lot of the newer like programs that are happening through different like Medi-Cal and other states are happening in the space of housing insecurity. So even if someone is like worried about losing their housing because they're unable to pay their bills, they're worried they might get evicted, those people are still housing insecure, and their situation, their discharge plan might change based on that. Unhoused is just lack of any regular, fixed, or adequate nighttime residence. And unsheltered is kind of that traditional picture that you think of. It's someone who's really not staying in a place that's meant for human habitation, such as like cars, parks, sidewalks, abandoned buildings, etc. I think a lot of times, like when we talk about like housing insecurity, we focus a lot on like individual stuff, or like this person is unhoused because they have a mental illness or a substance use disorder, or they have a lot of trauma, or other things like that. I think we rarely kind of name the larger like structural and infrastructural causes. And when I say infrastructural, that's kind of like a movement toward trying to really name the oppressive forces that are causing any form of oppression, including like housing insecurity, which is like a form of economic oppression. Unfortunately, like one of the big critiques of like structural violence is that it's kind of nebulous. So you can't really say what's causing it. It's just like, oh, there are these things like poverty. Poverty is causing homelessness. And it's like, okay, what do I do with that, right? Because like, I can't just like, how do I fight poverty? I mean, it's impossible. So we really have to talk more about these more larger kind of root causes of things like housing insecurity or houselessness or any other like oppressive practices that are happening or being inflicted on our patients. And I always have this slide in like every talk I give, partly because my partner's a psychiatrist and she's like grilled this into my head, but also because I think it's really true. You cannot provide trauma-informed care, and you cannot even really work in these spaces without really doing your own work. If you don't understand your own power and privilege in interactions with patients and in spaces in which you're working with community organizations, you cannot be anti-oppressive yourself, and you're just gonna replicate trauma that's already been inflicted upon people. So this is really important, and I also just want to emphasize that even though this is personal work you have to do, this personal work comes also in this circle of larger forces that are being enacted upon us and upon our patients that are really much more difficult to deal with on an individual level, but are related to our own understanding of our power and privilege. So let's talk a little about capitalism. We never talk about it enough here in medicine, but really capitalism is probably the biggest driver of all housing insecurity. And why is that? Well, that's because capitalism's main goal is the accumulation of capital. And you need bodies for labor in capitalism. And so you need to have bodies constantly circulating. That's what causes a lot of migration, like I do a lot of migration work too. And as people become more dispensable in that process of these bodies circulating, they kind of are seen as waste or like refuse that we can kind of like push to the side because they're no longer helpful to the capitalist accumulation of wealth. And we have homelessness because society and our economic system allows for it and creates it, not for any other reason. There's plenty of housing, there's plenty of money. It's just really a distribution issue. And I think this is like a really good graph, like it's been talked about a lot, but it just goes to show that over the last 30 to 40 years, really the distribution of wealth from capitalism has been very, very unequal. And in line with this and related, another very large cause of housing issues is white supremacy. And I like to call it white supremacy instead of racism because I think that, the cause of racism is white supremacy. So we're just trying to like bring it back to the very top level of what is actually causing this. And I think partly in America, and just talking about America, but I think this is really applicable in a lot of parts of the world. A lot of like the history of our country is based on displacing people from their land. Talk about we displaced Native Americans. We also displaced a lot of like brown and black people from their original homelands. And because of that, you can see here that black people are 5 times more likely to experience homelessness than white people, and Native Americans are 4 times more likely than white people. And if you look down and you actually take a look and just look at like, economic inequalities and you say, does that explain everything? Well, it doesn't. In addition to that initial displacement, there's also been just institutionalization of housing discrimination through redlining and a bunch of other things that happened in this country which kind of institutionalized housing insecurity across the board for people who were not white and were not privileged. And then lastly, the responses to homelessness almost always demonstrate many tenets of white supremacy. So a lot of organizations that deal with housing insecurity end up reproducing white supremacy in the way that they're responding to housing crisis, which kind of exacerbates the issue. Related to that, we have incarceration, and this is obviously an intersecting with white supremacy and overall economic inequality, but you can see that homeless rates among formerly incarcerated people are a lot higher than the average. This is, I think, the number of people in 10,000 that currently are unhoused, and you can see that the general public is 21, and these are through different economic and racial groups, how it kind of plays out for people who are formerly incarcerated. And lastly, there's a lot of like perpetuating causes, and these are just some of them, I'm not naming them all, but I just wanna point out that we need to like kind of do a better job of like naming what's causing this, is criminalization and policing. Unfortunately, police departments are highly influential in homelessness policy making, and you can see actually in figure 1 that when they asked mayors how influential each of the following groups are, the police are number 3, and people at risk of or experiencing homelessness are only 4th as influential. And we're like way down at the bottom, hospitals and healthcare, in determining policies around housing insecurity. And equally, you can see that these people who work in these different homeless outreach teams, a lot of times, it includes the police who come in and criminalize people who are unhoused, usually not because of, or almost always not because of anything that they've done on their own. And then 43% of these teams include encampment removal. So you have homeless outreach teams, which technically are supposed to be serving the people, who are coming in with police and then removing encampments as what we consider to be like support for the unhoused populations. So I think a lot of these things are just good to keep in your mind when we're talking about how to treat our patients in the emergency department, because this is the context in which they're coming to see us.
So I've got a few questions and say oh no, it's not gonna work at all.
It's
Okay.
not gonna work. It'll make the whole thing crash, unfortunately.
Okay, so we're gonna skip over the questions. I will.
I think if you,
I think you might have to exit.
oh no, if you go forward.
Will it jump it at all?
I keeps wanting to do that. Can I drive for a second? 'Cause
Yes.
I think
Okay.
I've figured out it's
I can at least ask my questions. I know them. So what percentage of homelessness, people experiencing homelessness suffer with substance use disorder? Do we think that it's 20 to 30%? 40 to 50%? 60 to 70%? Higher than 80%? Okay, so it's typically around 60 to 70%, depending on the study that you're looking at, and that's all forms of substance, including alcohol and opioids. And then what percentage of sheltered homeless do you think have a severe mental illness? I'll emphasize the word severe mental illness. So is it 70 to 80, 50 to 60, 30 to 40, 20 to 30? So it's actually our lowest group. The severe mental illness, where it's incapacitating for them, is actually only about 26% of people who are sheltered. I will say that's the sheltered population, and we know that the unhoused homeless and overall homeless is probably higher than that. But we kind of threw out the statistic. That was one of the first questions that we tried on our poll everywhere, was actually between 4 and 5%. 1 in 20 people experience homelessness for at least 1 month in their life, at least one time. So there's more than 20, there's more than 40 people in the room. So statistically, at least 1 or 2 people in this room, probably not in this demographic, but statistically, at least 1 or 2 people has probably lived homeless for at least once in their life. So I'm gonna go through kind of some of the background statistics. We do know that from 2022 to 2023, we saw a 12% increase in homelessness. This is the biggest jump that we've had in the past several years. So there's now over 600,000 people living homeless in America. There is a male predominance of that, and about 30 to 40% are actually living in that unhoused population, and it's actually relatively symmetric between men and women. And then this graph is kind of showing specifically the unhoused population. We see a disproportionate burden on our minority populations. And then to highlight our LGBTQI, specifically the transgendered population, are disproportionately unhoused comparatively. So more on the demographics, we're seeing this is an aging population. This is a disproportionately minority population. And this graph is showing, actually by the numbers, it is more white people, but proportionally, it is more minorities when you look at the per percentage in the US. And again, to highlight our transgendered community, 1 in 5 to 1 in 3% of people who identify as transgendered experience homelessness. And we compare that to that 1 in 20 statistic of our normal population in the US. So it really highlights, and say what Hannah was talking about, of we're seeing these racial disparities, these transgender disparities among this population. So moving on to the demographics of medicine, I don't expect anyone to read that graph, but the thick black line is our homeless population for their different disease. But we see higher rates of every single disease in people who are homeless. So that means higher burden on our healthcare system. So highlighting hypertension, COPD as being their more common ones. The mental illnesses, of course, are much higher among this population, especially our anxiety and depression related diagnoses are exceptionally high. And I want to talk about some of the reasons that contribute to that. And then to highlight what I would consider a disease that's not typically on my radar in the general public in the US, HIV and TB. Those are rarely in my differential when I'm working in this country, but are very high in this population comparatively. So to be thinking of that, this just kind of highlights we're comparing these same disease rates in homeless versus not homeless or housed population. So the impact of that, the reason that we're all here as ER providers talking about it is what does that do to our healthcare system? So a lot of the studies will show that homeless are 3 times more likely to show up in our emergency department. We also know that they're about 10 times more likely to die of the same diseases, and usually about 10 to 15 years younger than the general public as well. So we see this higher mortality rate, 6 to 8 times higher in men and 11 to 13 times higher to women. It's very subjective depending on the study that you pull. But this is actually one of the interesting things I found doing in my lit review for this is the only population where women don't outlive men, is the homeless. And nobody knows why. There's lots of ideas and things, thoughts going into it, but typically women outlive men. And that's true across all demographics, all races, all ages, except for people experiencing homelessness. So moving on, so why do we see this huge impact, of course, is all the things that come with living unhoused. You don't have safety, you don't have reliable food, you don't have reliable shelter. If you don't have a shelter, you don't have somewhere to bathe yourself. You can't wash your hands before you eat on that rare occasion you do get food. If you don't have stable housing, you're not gonna have regular meals, refrigeration, the ability to store things up. Maybe you actually do get your hands on your medications. Where are you gonna keep your medications for the month, for the 3-month supply, that no one's gonna steal them? Or if it's insulin, we saw the rate of diabetes. Who's gonna refrigerate that insulin to keep it effective for the month? And so I always like to throw out Maslow's hierarchy of needs, because to us as the provider, I'm like, this makes so much sense. They should just do X, Y, Z and take care of themselves better, and they'll have such a better life. But when you don't have a roof over your head and food in your belly, preventative health care, going and seeing a doctor is nowhere on the bottom of your triangle, and you're not gonna get there. And then my last point on this is victimization. And so we see that victimization is one of the very unique things that is both a contributor and a consequence of living homeless. So a large proportion, I don't remember my statistic now, 1 in 4 women cite violence, interpersonal violence, as a cause of them becoming homelessness. I talked in my research that a majority of people, a lot of women especially, are living with their partners, and the man is the one on the lease. And so women are at high risk of being that housing insecure, if that relationship goes bad and they're homeless in an instant. And so that violence contributes to that. And then almost 50% of people who are living homeless report that they've been victimized within the past year of living on the streets. So we know that this is a population that's going to get targeted for nothing more than where they are living. We also see them as high rates of motor vehicle collisions, especially pedestrian versus auto. I can think in my I'm a fellow, so very short career. I don't think I could name more than one incident of pedestrian versus auto that was not a person who was homeless. So with that, I'm going to turn it over to Dr. Russ, who's going to talk about more of this impact on our healthcare system.
Okay, so I swear this whole presentation is like a comedy of errors. I just want to thank you all for coming, and maybe I should stop here. No, when talking about the research, I'm here to talk about sort of, what do we know, how do we know it, and what are we perpetuating? This word cloud up here is from one of my former presentations, just asking people to put in free text, their association with homelessness and ED care. I don't think there's anything super surprising that that's what ended up being the word cloud. But I think that as a researcher who works in this space, for me, I saw a lot of ways in which I could work to challenge this. Oh no, more poll everywhere. There's got to be a way to skip slides, right? So, okay, I'm just gonna ask my questions with the hand raise, because I know what they are. What percentage of people experiencing homelessness report visiting an ED in the past year? Is it 0 to 20%? 20 to 40%? 40 to 60%? 60 to 80%? More than 81%. Okay, all right. And this is where I'm gonna try and not get stuck on my poll everywheres. What percentage of ED patients are unhoused? Slightly different, right? What percent of ED patients are unhoused? So 0 to 5%. 6 to 10%. Okay. 11 to 20%. 20 to 30%. Greater than 30%. Yeah, that's pretty high. I agree. All right, I'm gonna see if it'll let me jump back in from the current slide. Yes, I'm winning. All right. So the answers to the questions are kind of it depends. It depends on who you're asking and how you're defining it. The literature is kind of all over the place. So how is homelessness identified? That's your first question. Did it come from a self-report? Did it come from a screening tool? Were we divining it from the health record with ICD-10 codes and large language models? And what was the sample population? It's a really big difference in the numbers if you're asking a nationally representative population versus sort of in the community folks who are unhoused but not patients. Whether you're talking to ED patients, if you're looking at claims data, or a whole healthcare system that can really give you lots of data. The sensitivity and validity of all of these is very context dependent, so it's important to look at these with a critical eye. Just to illustrate this example, so community-based studies. So those are the ones where you're gonna go into the community, you're asking folks who are experiencing homelessness currently, how many times did you go to the ED in the past years? There's several studies that have done this, and they all come out with a ballpark of about 50% went to the ED in the past year. And only about 10% went more than 3 times. That's not quite the picture that we have in our heads. And then if you take national survey data, there's like this NESARC study, if anyone's familiar with that. It's really big. And there's also national surveys of clients who are experiencing homelessness. Only about 20 to 30% visit an ED this year, and less than 2% went more than 5 times. Again, that's not what I had in my head, right? And then let's go back to the ED patients. So we'll subset in there. So I bet a lot of people in here have used NEDS and HAMCs, these like national data, claims data. They want to tell me that it's less than 1% of patients experiencing homelessness. I don't think that's right either. I'm like, where's that coming from? I mean, I guess it's averaged over the whole country. I could tell myself it's that. They're also relying on ICD-10 codes, which ICD-10 codes, you can have some Z codes, but we only put Z codes in 2% of our patient charts, and that's all social determinants, all of those codes. I think more than 2% of our patients have social vulnerability. So yeah, that's not right. Single center studies vary a lot, makes sense, right? They're ranging from 7 to 30%, depends on, urbanicity, safety net hospitals, teaching centers. So, okay, I'll buy that, but then that's only one center, so what does that tell me? And then you get into you can talk about unique individuals, and then you talk about the visits. That's like a whole nother layer, right? Because we keep reading all these statistics that homeless patients are frequent flyers, terms I hate, right? That someone who's unhoused is 5 times more likely to be a super user. But it's 5% of the users are accounting for 50% of the visits. So maybe we need to contextualize that a little bit more in our discussions when we find these findings. And I'm going to say this, I've written papers that say things like this too. I'm guilty of this myself. It's you find a significant finding and then you put it in the conclusion, but the way you're contextualizing it, it's kind of perpetuating some of this stuff. So okay, let's just accept the premise that folks who are unhoused use the ED a lot. I won't belabor this because I think Christine covered it pretty well, but you've got folks who have high incidence of trauma, high incidence of mental illness, substance use disorder, and medical comorbidities that they're struggling to manage in a fractured healthcare system with poor transportation and no way to store their meds. So it seems kind of legit that they would need to use the ED. Those are all going to come together and kind of come in there. But yet we have this narrative of unnecessary use, or people are there for, what do we see up there, turkey sandwich? I don't know. Oh no, why did I put poll everywhere? Okay, but I'll tell you what the question is while I reload it. All right, so show of hands. What do you think is the most common reason for ED visits among people experiencing homelessness? And I'm gonna give you a few options, so I'll give you a chance to vote. The first one's gonna be traumatic injuries, alcohol and drug-related use, psychiatric visits, and none of the above. So let's start with traumatic injuries. Substance use. Psychiatric. Did it come up? A lot of people didn't vote. I think you guys know I'm trying to trick you. That's all right. But yeah, it's mostly trauma visits, right? The motor vehicles, the victimization, and self-inflicted harm, right? Because you do have some psych stuff going on. So I mean, that's kind of a trick question, right? Because that's a twofer. And it's not to say that the alcohol and drug-related visits or the psychiatric visits aren't real issues, right? This should be part of patient care. 20% of visits are still for those reasons, and we need to have good services that are sensitive to the context of being unhoused and struggling to follow up. And, if someone's there for that traumatic injury, the odds of them having a substance use disorder are super high. So I'm not trying to say that none of these like misconceptions are total misconceptions, but it's just important to put them in the context. Another outcome we really love in health services research is length of stay and costs. Okay, so folks who are unhoused have longer hospital stays. Okay, and they're more expensive. Okay. But they're also 5 times more likely to leave on a self-discharge, or what we call against medical advice. And that's because they have curfews at their shelter. They might lose their shelter spot altogether. Their belongings are in an encampment that's gonna get stolen. And I wanna point this out here, that these are odds ratios for discharge against medical advice among folks who are unhoused versus stably housed. It's not psychiatric and substance use up here. We've got sepsis, MIs, respiratory failure. Like those are all kind of serious medical conditions that have real morbidity and mortality if they go untreated. You know, so you have to think like, man, losing my tent and my belongings is really compelling because I'm walking out on my MI. Okay, so again, we really love to measure healthcare use. We love to see like, did ED visits go up or down if I gave them housing or if I did this intervention? And it's really hard to randomize housing. It's expensive. If you figure out a way to give houses to people on an R01, please call me. I would love to be able to do that, but it's very expensive. But a few places have done it. They found ways to either introduce randomization into the supportive housing structure and partnered with cities. And so there have been several cities in the Chez Soi study that's in Canada. Some great work just came out of Denver, Los Angeles, Chicago, where I've done some of this. And it's all over the place. Some people are like, oh yeah, ED visits go down. Others are like, no effect. Some people are like, primary care went up. Some places it just went up. I mean, I guess if you give people stable housing, you might expect to see them be able to engage with healthcare. Maybe you want that, right? So I just want to problematize this whole idea that like providing people with housing doesn't have to be justified by healthcare cost savings. We're a rich country. We can give people housing because it's the right thing to do, and we're not responsible for proving that it had value. Oh, thanks, guys. Caveat, there may be a time when it is appropriate to measure that, but let's make sure we have a hypothesis-driven reason, right? So ED use does signify substantial medical and social needs, and so maybe you have an intervention and you expect it will decrease that use. Okay, fine, measure it. Maybe you have an intervention that's gonna improve access. That's hypothesis-driven. Yeah, okay, see if they use more. Maybe you actually are gonna want to see the increase in access, like we said. Maybe you're doing some quality improvement stuff in your own individual shop and you need to collect that data for that reason. All totally legit. I don't want to say it's never. You never say never, right? Whenever the answer is never, it's not the answer. But do consider alternative measures. You know, did outpatient visits, routine care go up? Were prescriptions filled for chronic illnesses? Housing stability itself should probably be an outcome, right? Like we give housing so people have housing, so did they keep housing? That's always a good one. Disease-specific outcomes, patient-centered outcomes. Try and think about ways that you can measure alternative outcomes in this. So just in conclusion of my section, research is powerful. The way we frame our conclusions have a lot of power to perpetuate these narratives that our colleagues take home, our residents take home, our patients take home. And so it's really important that you're addressing your own bias in how you're framing that research question. And the best way to combat that is ethical practices in research. Have folks who have lived expertise in homelessness on your advisory board. Have people who work in community service organizations as part of your research team. Have them tell you what their needs are, what they think is a good research question. Nothing about us without us, right? I think that concludes my TED Talk, but I'm gonna hand it off. And you're gonna talk about solutions.
What a tough act to follow. Thank you, Caitlin. So we have maybe, let's see, 10 minutes, 12 minutes left. So I'm going to talk a little bit about interventions, and then I want to leave some time to have a small group discussion and kind of hear some ideas and your experiences, what you're doing in your shops to care for patients with homelessness better. So what can we do? Of course, as Hannah mentioned in their part of the talk, the drivers of homelessness are societal, and so ultimately the fixes for homelessness will be societal as well, right? So we care for these patients in the healthcare setting, and so the care we provide matters, but it has to be acknowledged. So housing first, of course, is helpful, but it's not housing only, right? So this means ongoing case management, social work, connection with services to address other social determinants of health that these patients experience. Of course, on an individual level, it's important to reflect on our own biases. Patients experiencing homelessness report high levels of stigma in their interactions with the medical system. And so it's important to think, how do I think about these patients? How do I interact with these patients? Because self-reflection is an important way to address our own internal biases. Of course, if we don't ask, we don't know. And so maybe you have screening in your emergency department if you are in a shop that cares for large numbers of patients experiencing homelessness. But if not, and it might impact your discharge plan, ask your patient. If you're concerned about the patient's ability to pay for medications, ask, how do you pay for your medications? These are important considerations when you're formulating a discharge plan. And if you don't ask, you won't know. For patients with material hardship, they know their circumstances and the implications going into their decisions better than we ever will. And so consider providing multiple options that are equally acceptable or maybe not unacceptable. And the patient can choose whichever option works for them given their circumstances. So a few interventions that have shown benefit in the emergency department. Of course, case management, ensuring that an ED visit is also an opportunity to address underlying unaddressed social determinants of health in addition to the acute medical need. I also mentioned street outreach, which not necessarily ED-based, but there's opportunities to connect patients who are discharged and remain unhoused with street outreach teams. And so partnerships with your local community-based organizations are another potential. Medical respite or recuperative care, depending on the setting. There's a number of organizations throughout the country. So these are facilities that provide some level of medical care that's lower than a nursing home, that's lower than an acute hospitalization for patients who are unhoused and have ongoing medical needs. Maybe they don't rise to the level of needing an inpatient hospitalization, but at the same time would not be well served by being discharged to the street or to a shelter. I want to mention tiny shelters. These are, you'll probably hear about them in the news. They're popular because they're politically feasible. They don't take up too much space. They're not cheap, but they're relatively inexpensive compared with permanent supportive housing. But they're not tiny homes. This is just a roof, a bed, a place to store your belongings. They don't include running water, kitchen facilities, bathrooms are located in a central shared location, and they should not be viewed as permanent structures. They're really just temporary transitional shelter. People experiencing homelessness and housing instability also face fines, tickets, which can present a financial burden to getting and paying for housing. People who are unstably housed may experience disputes with their landlords that lead to eviction, which can lead to homelessness. And so medical legal partnerships are an important consideration to address these factors, which also impact these patients' care. And then patient navigation is also a consideration. So patient navigators typically come from the communities they serve and help address barriers. They've been shown to affect follow-up care and quality of care for a number of disease states, including ED visits for patients who come to the ED frequently. Sorry, Caitlin. I don't mean to emphasize ED visit reduction too much. And so that's it. That's our talk. But now we have some time left, and so we really want to hear from you all. And so we're going to have 4 not so small groups because we have a really great group of people today. And we want to hear from all of you. So if you could please self-select into education, advocacy, research, and operations in this front right corner. If you can relocate here if you're interested in research. In sort of the back right corner, we'll do education. The back left corner, we'll do advocacy. And then front left, we'll do operations. And we'd really like you to think of an intervention, maybe something that you're trialing in your own institution or that you've heard about today, and then think about what would be some barriers and facilitators to impact the feasibility if you were to do that in your ED. Or, better yet, if you're trying something, what were some barriers and facilitators that you experienced when you were implementing this? And then what outcome measures would we consider to evaluate the intervention?
All right, everybody. I think the next group is coming in for the room. I just want to thank you all for coming to our didactic and for engaging and all of the really interesting conversations. I just want to make sure we surrender the space. For anyone who's interested in the many sources that we referred to, I don't like to clutter slides. Feel free to grab the QR code before you walk out.
Thanks so much, everyone.